Welcome to AETCM, the emergency medicine channel. Today in this video, let's discuss regarding the key updates of 2025 American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. So recently AHA has given new updates. So we'll see what are all those updates in this video. So the 2025 guidelines mandate a unified chain of survival, eliminating the previous distinction between adult and pediatrics as well as in-hospital cardiac arrest and out-of-hospital cardiac arrest. That means in the previous guidelines, there is separate chain of survival for adult patients, for pediatric patients, for out-of-hospital cardiac arrest victim and for in-hospital cardiac arrest victim. Now, as per this current guidelines, the AHA has given a unified single chain of survival for patients who are undergoing for cardiac arrest. Okay, the 6 links of this chains of survival includes. So that means if you see a cardiac arrest victim, either he might be an adult victim or pediatric victim or the cardiac arrest that might be happening out of the hospital or inside of the hospital, whatever it may be the situation, we have to follow these 6 links. We'll see what are all those 6 links. The first link is recognition and emergency activation of emergency medical services. First thing is we have to recognize what is the reason for cardiac arrest, and immediately we need to activate emergency response system. That means we need to call for help and we need to activate emergency response system. That is our first link in the case of chain of survival. Next thing is high quality CPR. So we have recognized what might be the reason for cardiac arrest and we have activated emergency response system. After that, we need, if there is no pulse and breathing, we need to perform high quality chest compressions. After making sure that if there is no pulse and breathing in a patient, we need to go ahead with high quality CPR, that is cardiopulmonary resuscitation. We know we have 5 high qualities of CPR, especially in the case of adults. So compression rate is 100 to 120 compressions in a minute. Depth of compressions is 2 inches or 5 centimeters. We have to avoid excessive ventilation and we need to minimize interruptions while performing CPR, and we have to allow complete chest recoil. So these are all the 5 high qualities of CPR and we need to perform. Then third link is defibrillation. So we know already defibrillation is a procedure that can be performed in patients who are having shockable rhythms of the cardiac arrest. We know we have 2 shockable rhythms of the cardiac arrest, that is pulseless ventricular tachycardia and ventricular fibrillation. If you have these 2 shockable rhythms of the cardiac arrest, we can perform defibrillation. If it is outside of the hospital, we have already activated emergency response system. They might get an AED so that we can use it as early as possible when they get the AED. If it is in hospital cardiac arrest, with the help of manual defibrillator, we can perform defibrillation. So what is the main advantage of defibrillation is it will eliminate the abnormal rhythm and it will restore normal sinus rhythm. Then the fourth thing is advanced resuscitation. So we have performed defibrillation. Now apart from defibrillation, advanced resuscitation is nothing but here we can use certain drugs for the management of cardiac arrest and we can perform advanced airway management, and these things will come under advanced resuscitation. That is your fourth link. The next thing is post cardiac arrest care. So we have performed advanced resuscitation and we have been continuing with high quality chest compressions. After some time, the patient might attain return of spontaneous circulation, that is reappearance of pulse and breathing. That means reappearance of signs of life. Once after attaining the signs of life, for the next 48 hours, we need to vigorously monitor the patient, and that phase is called as post cardiac arrest care management, and which is our fifth link. And once after giving proper post cardiac arrest care management to the patient can be recovered both mentally and physically, and he might be survived, and we can discharge the patient once the patient becomes all right. Okay, these are all the 6 links of, in the case of, these are the 6 links of chains of survival in cardiac arrest victim, and it is common for both adult patients, pediatric patients. If the cardiac arrest that is from outside of the hospital or from the inside of the hospital, we have these 6 links. This is the new update that has we got from the AETCM. Then rescuer position, next update is rescuer position. That means the person who is performing chest compressions, he is called as a rescuer, and the patient torso, that means if you have a cardiac arrest victim, the patient's torso should be approximately at the level of rescuer's knees. That means when we are performing chest compressions, we have to make sure that our patient's torso should be at the level of our knees, so that we can perform effective chest compressions, we can maintain depth, and we can improve the compression rate, everything. So that is one update. So make sure that patient's torso should be at the level of rescuer's knees, so that it is easy for the rescuer also to perform the chest compressions in an effective manner. Then next thing is resuscitation education. So AHA is recommending that mandatory feedback devices. There is a strong recommendation to use instrumented feedback devices during the professional and lay rescuer CPR training to objectively measure performance. So when we are conducting regular training sessions to lay persons and students also, so we have to make sure that every person should use feedback devices. So if you use feedback devices like metronome, wristwatches, we can monitor the depth of compressions, we can monitor the compression rate, all these things, and ultimately if we have feedback devices, we can measure even chest compression fraction also. So please make sure that when we are performing chest compressions, it is advisable to use feedback devices during training session and during the resuscitation of the cardiac arrest victim. Then let's see the basic life support 2025 updates. So I am discussing regarding the key changes only. So first thing, opioid overdose. Now they have integrated naloxone in the basic life support algorithm. So if you have opioid toxicity and the patient is in cardiac arrest, because of the cardiac arrest is because of the opioid overdose, we can go for naloxone administration. And AHA is suggesting that you give naloxone to the patient and made this naloxone accessible to the public, so that they can use it, even lay persons can use it, so that we can reduce the fatalities of patient with opioid toxicity and cardiac arrest. Then next update is adult choking. So as per this thing, if you have an adult patient with severe foreign body airway obstruction, what we need to do is we have to give 5 back blows followed by 5 abdominal thrusts. 5 back blows followed by 5 abdominal thrusts. This is the recent guideline. So in the previous guideline says that we have to follow only 5 abdominal thrusts, that is below to the level of your xiphoid process of the sternum, above to your umbilical region. You can make a fist and you can start giving 5 abdominal thrusts. That was the previous update. Now the current 2025 guidelines suggest that you give 5 back blows followed by 5 abdominal thrusts. So these 5 back blows where we need to deliver is in between 2 shoulder blades. With the help of heel of your hand, you can start delivering 5 back blows followed by 5 abdominal thrusts. This is one major update, and until the object is expelled or the person becomes unresponsive. So you give these things. If the patient becomes unresponsive, and we know we have to lie down the patient and we have to proceed with the basic life support algorithm. Okay, this is one major update. I hope you understood. Then next thing is, in adult with head and neck trauma, if the airway remains obstructed despite a jaw thrust maneuver and the use of airway adjuncts, trained rescuers may proceed to open the airway by using head tilt, chin lift technique. We know we have airway maneuvers for opening the airway. So we have 3 airway maneuvers: head tilt, chin lift, jaw thrust. So if you are suspecting a C-spine injury or spinal cord injury, usually to prevent further damage to the C-spine, we will be going ahead with jaw thrust maneuver for opening the airway, especially in trauma patients. But In the cases of cardiac arrest, where if you have a patient with head and neck trauma, if you can't able to open the airway by using jaw thrust maneuver, it is advisable for the trained person, he can open the airway by using head tilt chin lift maneuver. Okay, because ultimately opening the airway might save the life of a person. So it is one of the update. And one more thing is, adults with obesity who experience cardiac arrest should receive CPR using the same methods applied to the non-obese patient. That means CPR, the method of performing CPR is same for both obese and non-obese patients. Then next thing, the routine use of mechanical CPR devices is not recommended for the adult cardiac arrest. So AHA is suggesting us that we should not use mechanical devices while performing CPR, especially in the case of adults. So that should not be done, because lot of studies suggest that the human, if we perform high quality chest compressions, that is more than, and the most of the guidelines they says that human compressions are effective. So mechanical usage of mechanical devices has not been advised by the AHA. Then next thing is, we'll see the ACLS 2025 updates, key changes, CPR quality, physiology guided CPR. So we have already discussed in the previous slides that we have to go ahead with feedback devices. So physiology guided CPR, we need to use monitorings. First one is arterial blood pressure monitoring, if it is possible. So you can use arterial blood pressure monitoring, and along with that end tidal carbon dioxide ETCO2 monitoring, that is called as waveform capnography monitoring. We know the waveform capnography has got a lot of importance, especially in the case of cardiac arrest, and it has got lot of uses. I'll tell you certain uses of waveform capnography. It is the gold standard method for confirming the position of endotracheal tube. And while performing chest compressions, if the ETCO2 values are less than 10 millimeters of mercury, we need to improve the quality of chest compressions. If you see a sustained rise in ETCO2, that indicates a return of spontaneous circulation, and we can monitor the ventilation, effectiveness of chest compression, all those things. So that's why it is advisable to use waveform capnography monitoring, and it is advisable to use arterial blood pressure monitoring. So these are all the two things, most important things. So we can use it so that we can measure whether there is an adequate perfusion to the brain is happening or not. That can be measured. So if it is advisable to use arterial blood pressure monitoring and ETCO2 monitoring. Then advanced airway, so supraglottic airway usage. So for out of hospital cardiac arrest, OHCA, for out of hospital cardiac arrest victim, the supraglottic airway is the recommended thing over endotracheal tube in settings where the success rate of tracheal intubation is low. So they were telling that it's better to go ahead with supraglottic airway device usage, that is LMA usage, in settings where endotracheal intubation is low, especially in outside of the hospital. If it is in hospital cardiac arrest, then we can perform endotracheal intubation because we will be having trained persons and all. But if it is out of hospital cardiac arrest scenario, there will be lack of resources and trained persons won't be there. So AHA is suggesting us to go for supraglottic airway device usage, that is especially LMA. Even if a trained persons are there, means even lay persons, paramedics, another healthcare professionals also, they can use it, and it has got lot of advantages. Then resuscitation of the pregnant woman, this is one more thing. So in order to resuscitate a pregnant woman, everything is same. We know left lateral uterine displacement of the abdomen has to be done, especially in the case of pregnant women, so that aortocaval compression will be reduced, blood will freely reach to the heart, and the patient will be alright. Apart from this thing, we should have a specialized maternal cardiac arrest team. This specialized maternal cardiac arrest team includes ER physician, anesthetist for the management of airway, obstetrician, followed by neonatologist and nurse. So like one team leader. So 6-member team with specialist also needs to be there, because sometimes we might have to perform perimortem cesarean section especially in the case of ER setting, if the patient is not attaining return of spontaneous circulation within 5 minutes, then we have to go ahead with perimortem cesarean section, especially in the case of ER setting. So for that we need to have maternal cardiac arrest team. Okay, and one more thing is, this is the most important update, is fetal monitoring should not be used during the cardiac arrest. So please make sure that we are mainly concerning on the mother. So if you have a mother, pregnant woman who underwent cardiac arrest, first you resuscitate the mother, then automatically fetus will be alright. So fetal monitoring should not be used during the cardiac arrest. So this is one of the most important update. The next thing is the effectiveness of IV calcium administration for adults and children in cardiac arrest from suspected hyperkalemia is not well established. So usually for hyperkalemic cardiac arrest, the agent of choice, the drug of choice is IV calcium gluconate. That is 10 ml of 10% calcium gluconate over 10 minutes can be given. That is what the previous guidelines say. But lot of studies, they have shown that the effectiveness of IV calcium administration is not well established, especially in the case of hyperkalemic cardiac arrest. So if it is a shockable rhythm of the cardiac arrest, you perform defibrillation, you go ahead with the usage of drugs. Even this IV calcium also can be given, but it is not that much well established. Then next thing is head up CPR and double sequential defibrillation. So heads up CPR is discouraged outside of the rigorous clinical trials. So AHA is discouraging heads up CPR. So while we are performing chest compressions, we have to make sure that we need to monitor the high quality chest compressions. We have to see what is happening, and we need to perform high quality chest compressions. Next thing, routine use of double sequential defibrillation is not recommended for refractory VF. So usually previous guidelines says that we can go ahead with double sequential defibrillation. So what is this double sequential defibrillation means? So we will be using 2 defibrillators at a time. So for eliminating this refractory VF or pulseless ventricular tachycardia. So after performing 3 defibrillation attempts also, if the patient is, the rhythm is not converting into normal sinus rhythm means, then we can go for double sequential defibrillation. That was the previous guideline, but recent guideline says that there is no need of double sequential defibrillation, especially in the case of refractory ventricular fibrillation. So please make a note of it. The next thing is vasopressin. The vasopressin has got no advantage over epinephrine. So ultimately our high quality chest compressions, our defibrillation, and along with that epinephrine usage might save the life of a patient. And antiarrhythmic drug, other antiarrhythmic drugs other than amiodarone and lignocaine, that is lidocaine, IV lignocaine, which is Xylocort, other than these 2 antiarrhythmic agents, amiodarone and lignocaine, rest of the other drugs has got no benefit, that is uncertainty in benefit is there. So beta blockers, pretilium, procanamide, sotalol, they have not got much benefit over these 2 drugs, that is amiodarone and lignocaine. Okay. Next thing, synchronized cardioversion. We know synchronized cardioversion is a procedure that can be performed in patients who are having unstable tachyarrhythmia with a pulse. If you have a patient with unstable tachyarrhythmia with a pulse, we have to go ahead with synchronized cardioversion. But previous guideline says that any energy less than 200 joules of energy, any energy less than 200 joules of energy can be given for performing synchronized cardioversion. But recent 2025 guideline says that if you have narrow complex tachycardia, if the QRS complex duration is less than 3 small square with tachycardia, you go ahead with 100 joules. They have given fixed joules. For suppose after giving 100 joules to the patient, we have performed synchronized cardioversion. If the patient is not improving with this thing, then you can increase the dosage of this synchronized cardioversion. Okay. Then if you have monomorphic ventricular tachycardia or tachyarrhythmia with pulse, then the synchronized cardioversion the energy will be 100 joules. Then atrial fibrillation, they have mentioned that it is 200 joules. If you have narrow complex irregular tachycardia without P waves, that is if you have atrial fibrillation, go ahead with 200 joules of energy. Then if you have atrial flutter, again you can go ahead with 200 joules of energy. And polymorphic ventricular tachycardia, that is torsades de pointes. Usually if we have a patient who underwent cardiac arrest, after connecting the monitor, if the patient is having polymorphic ventricular tachycardia which is torsades de pointes, usually if you check for pulse and breathing, there will not be pulse and breathing, so most probably the patient will be in cardiac arrest. So during those conditions, it is better for us to go ahead with defibrillation dose. That is, defibrillation dose means the maximum dosage that is available on the defibrillator, that we can select maximum amount of energy, we can charge the defibrillator and we can discharge. So if you have polymorphic ventricular tachycardia, go ahead with defibrillation dose or the maximum joules of energy that is available on the defibrillator. Then we have already discussed regarding the antiarrhythmic medications. The sotalol has been removed from the tachycardia algorithm. Then terminology updation. So they have changed supraventricular tachycardia to narrow complex tachycardia. So these are all the main updates, especially in the case of tachycardia algorithm as per 2025 guidelines. Okay. Then if you see the post cardiac arrest care management. So post cardiac arrest care management, previously we used to call it as targeted temperature management. So when we have to keep the patient on targeted temperature management, we will be having certain targets and we will take the 12 lead ECG. So we'll send the patient to cath lab, we'll see is there any need of extracorporeal therapies, all those things. We will be checking everything and we'll assess the response of the patient. We will be checking whether the patient is responding to your commands or not. If the patient is not responding to your commands, usually we'll keep the patient on targeted temperature management. So the targeted temperature management terminology has been changed to temperature control. Now it is temperature control. So what is this temperature? The range of this temperature is, it is in between 32 degrees Celsius to 37.5 degrees Celsius. Okay, this is, we can say this 37.5 degrees Celsius might be the normal temperature, and it is 32 degrees Celsius is the hypothermic state. Okay, whatever it may be, you maintain the temperature in between 32 degrees Celsius to 37.5 degrees Celsius. So maintain temperature for at least 36 hours for non-responding patients. This is the key updates. Previously they used to say that it is the temperature should be maintained for 24 hours. Now it is for 36 hours, especially for non-responding patients. Then it is permitted for out of hospital cardiac arrest patients with ROIC. So if you have a patient who underwent cardiac arrest outside of the hospital after attaining return of spontaneous circulation, for those category of patients also you keep the temperature control in between that range for the next 36 hours. Then avoid cold IV saline infusion. To bring back the temperature to the normal level, please don't go ahead with cold IV saline infusion. Again, it may cause coagulopathy, lot of complications and all will be there. Slowly you can keep ice pack and all. Slowly we can reduce it, we can bring back the temperature to the normal level. Then next thing is maintain mean arterial pressure of greater than 65 millimeters of mercury. So if you have a mean arterial pressure of greater than 65 millimeters of mercury, there will be good perfusion to the brain. So that's why maintain a mean arterial pressure of greater than or equal to 65 millimeters of mercury. And next thing is maintain oxygen saturation of 90 to 98%. Previous guidelines says that it is in between 92 to 98%, but now they were telling that it is 90 to 98%. But we should not give 100% of oxygen to the patient. If the patient is having hyperoxia, it will produce free radicals and it will damage the brain. So that's why 100% of oxygen saturation has been avoided. So keep the saturation of the patient in between 90 to 98%. Then thrombolytic therapy. So tenecteplase as an approved thrombolytic agent for acute stroke. Okay, previously it was altiplase. We have to give altiplase as an infusion, so certain complications were there. Now they have added tenecteplase as an approved thrombolytic agent, especially in the case of acute stroke. Then acute coronary syndrome, especially MI and all. So they have removed LBBB, left bundle branch block, as a definitive diagnosis for STEMI. We can think in terms of Scarbosa criteria, Smith's criteria, all these things, we can use that thing. But alone LBBB, they have removed LBBB as a definitive diagnosis for STEMI patients. Then they have removed clopidogrel as a primary agent, that is antiplatelet medication. They have used, now they were telling that certain other medications like ticagrel, prasugrel has got much more efficiency when we compare to the clopidogrel. So they have removed clopidogrel as a primary medication. Then they have added fentanyl, opioid analgesic, for secondary pain control in addition to the morphine. So in the previous algorithms, ACS, if you see ACS algorithm and all, there was only morphine. Now they have added fentanyl for the pain control. So what is the main difference why they might have included fentanyl is, so it won't produce much hypotension if you compare to the morphine, and the complications will be less when you compare to the morphine. So go ahead with fentanyl usage, especially for pain control in MI patients. Then they have included enoxaparin or fondaparinux as anticoagulants, and AC inhibitors also they have included. AC inhibitors like isinopril, captopril, enalapril, they have included these drugs for the management of acute coronary syndrome. These drugs mainly, it will remodel the heart and it will protect the heart for longer periods of time. So usually it is an antihypertensive agent, so with heart failure we can give. So they have included AC inhibitors for the management of ACS. Then when we come to the airway and ventilation updates, they have removed fixed volume recommendation of 600 to 800 ml for ventilations. Okay, so there was a fixed volume, that is 600 to 800 ml of tidal volume has to be delivered, but they have removed this thing. So instead of this thing, what they were telling is, you squeeze a bag to 1/3 to 1/2 of the bag, so that there should be visible chest rise. This is the main thing. So whenever we are performing ventilation with the help of bag wall mask device, please make sure that whether visible chest rise is there or not. That is our observable indicator that we are giving effective ventilations with the help of bag wall mask device. It is not about fixed tidal volumes, that is 600 to 800 ml. So that's why they have removed it. Then next thing, so few key 2025 PALS updates. So epinephrine timing. So early epinephrine for non-shockable rhythms. We know we have two non-shockable rhythms of the cardiac arrest, that is asystole and pulseless electrical activity. So for infants and children with an initial non-shockable rhythm, that is asystole or PEA, administration of epinephrine as soon as possible is reaffirmed and associated with improved outcomes. So if you have a patient who was having non-shockable rhythms of the cardiac arrest, that is asystole or PEA, especially we are discussing regarding PALS updates, you directly go ahead with, as early as possible, directly go ahead with the drug adrenaline. The dosage of adrenaline is again 0.01 mg per kg body weight, and it has to be repeated for every 3 to 5 minutes. Okay, then this is one thing. So especially in the case of non-shockable rhythms of the cardiac arrest, the chances of recovery will be very high if you give adrenaline as early as possible. The next thing is infant chest compression technique change. So the 2-finger chest compressions has no longer taught. So they have removed 2-finger method of performing CPR, especially on infant age group. So previously we used to say that we can perform 2-finger method for performing CPR, especially in infant age group. Now they have removed it. What they are recommending is, they are telling us to perform 2-thumb encircling method, or we can perform chest compressions with the help of heel of one hand. So either we can perform thumb encircling method, but I would say this 2-thumb encircling method, can be performed if you have 2 rescuers, so that you can perform CPR on the infants with the help of thumb encircling method, and one more person he might be using AED and he can deliver rescue breaths, all those things. But if you are only one rescuer is there, it's better for you, you can go ahead with heel of one hand. This will be applicable even in the case of infant age group also. With the help of heel of your hand, with the same position, we can perform high quality chest compressions. So they are recommending the usage of thumb encircling method and usage of heel of one hand for giving effective chest compressions, and they have removed 2-finger method for performing chest compressions. The next thing is choking management. If you have a child who is greater than or equal to 1 year, that is greater than 1 year, we have alternate 5 back blows, 5 abdominal thrust. So this will be a bit tricky here. So in the case of adults, we have discussed 5 back blows followed by 5 abdominal thrusts. But if you have a child who underwent cardiac arrest, if the age of the child is greater than 1 year, you can again perform the same thing. You can perform 5 back blows followed by 5 abdominal thrusts. I hope it is clear. And if you have an infant with less than 1 year age group, what you can do is, you can perform 5 back blows and 5 chest thrusts usually. So we know already this is same. So if we have an infant, we can perform 5 back blows, again same position in between 2 shoulder blades. With the help of heel of your hand, you give 5 back blows followed by 5 chest thrusts. Whatever it may be, the mechanism behind delivering these 5 back blows and 5 chest thrusts is, we are generating a pressure. Because of this pressure, the object will be coming out. If the object is not coming out, or if the patient becomes unresponsive, again you can follow your infant or pediatric BLS. Okay. Then CPR quality monitoring. So they have given diastolic blood pressure targets if there is an arterial line placement. If you have a patient who was already having arterial line in place, then we can monitor diastolic blood pressure to confirm the effectiveness of chest compressions. That means if the diastolic blood pressure is good as per these targets, then we can assure that blood is freely reaching to the brain properly. So that's why if you have an infant cardiac arrest, target for a diastolic blood pressure of greater than or equal to 25 millimeters of mercury, and if you have a children, target for a diastolic blood pressure of greater than 30 millimeters of mercury. Why these targets are very important means, if you maintain these targets, we can assure that blood is freely reaching to the brain. Okay, that is one thing. So maintain diastolic blood pressure targets if we have an arterial line. Then post cardiac arrest care. So here also, especially in the case of pediatric age group, avoiding hyperthermia, fever, avoid hyperthermia. Okay, preventing the central temperature of greater than 37.5 degrees Celsius can improve neurological outcomes. So this is one of the important thing. So if you allow the pediatric age group patients temperature, if it is more than 37.5 degrees Celsius, once after cardiac arrest, fever is more toxic to the brain. So if you are allowing the patient to go for fever, it will be having its vulnerable effects on the brain. So make sure that you maintain the temperature in between normal range, that is we have already seen previous 32.5 degrees Celsius to 37.5 degrees Celsius. So if you maintain temperature in between that range, we can have a good neurological recovery. If you allow the patient to go into more hypothermia or hyperthermia, it will be having its own complications. Thank you for watching.